This conference will now be recorded.
Okay, so welcome to class. And what will be the plan today? So first I'll be explaining about Forceps, Ventouse, and about rotational deliveries. That would be of help for part 3 stations and also for part 2 solving questions. Then we'll be doing guideline. Then there will be question session. Okay. So anytime if I'm not clear or so you people can stop me anywhere and you can ask questions. Okay. So first of all, this is from the new guideline. This slide is more important for part 2 people because these are the all numbers from where the questions can come. This is a slide from where the questions can come. Okay, all numbers are there. So incidence of operative delivery is 10 to 15%. Okay. In primipara, it is 1 in 3. So this is a new number added in this guideline. So this number is important. Now, what will be the complications that can happen with the vacuum and what can happen with the forceps? So many of the time these questions are coming so it is important to remember this number. Even this numbers has to be is required for part 3 people also, because if the role player asks you some questions about tears and about PPS, so you have to answer those questions. So this forcep in vacuum number is important for both of you, both of part 2 and part 3 people. So usually if you find, if you, it will be easy to like remember. So for forceps, everything will be like multiply by 2. So if the vacuum has to be applied, so episiotomy will be 50 to 60. But if you think it is almost nearly double, so in forceps 90 percent of the patient will require episiotomy. This number is usually asked by the role player in part 3 station. So you have to say 9 out of 10 women will require episiotomy in forceps. Here it is almost double in forceps. So it is 10% for vacuum and it is 20% for forceps. This oasis or third or fourth degree tear, it is 1 to 4% in vacuum and almost near to double or 2 times to 3 times, it is 8 to 12% in forceps. This number has you both for appearing for the part 2 and part 3 people. This number has to be remembered by everyone. Okay, and there is increased bleeding after operative delivery. So this is 10 to 40%. Okay, so these are the important number nobody can forget. You have to do this. These numbers, that fetal injury numbers, often on sometime they are asked in exam. So these numbers are important, though there is a consent is also there for operative delivery. The numbers are almost same as given in the consent, but again you have to do it from the guideline because it is recently updated. So Kefal hematoma, it usually happens with a vacuum and it is 1 to 12%. Lacerations, fetal scalp lacerations with combined with either with a vacuum or forceps, it is 10%. Retinal hemorrhage, 17 to 38%. This is the commonly asked question about retinal hemorrhage. You have to remember this. Jaundice is 5 to 15. Subgaleal hemorrhage, it happens in vacuum only. Okay, this subgaleal hemorrhage, because there is a formation of the xenon, and if that cup of vacuum is not applied correctly, then there is a possibility of this subgaleal hemorrhage, and it is 3 to 6 in 1000 deliveries. And intracranial hemorrhage, this number is also asked sometime. It will be 5 to 15 in 10,000. Nothing to no, there will be no query in this slide because these are all number. So we have to remember. So this part of the before fetal, like this part is important for both part 2 and part 3 people. I'll share the screenshot in the group so you people can just go through it. Now this part is important, like instrumental delivery, what they are assessing non technical skills. Okay, and they are assessing situational awareness and communication. So these are the component if they are coming from the for the part 2 exam. So somewhere they can ask about what type of skills. So answer would be non-technical skill. And for part 3, you already know that in instrumental delivery they are checking your non-technical skills, your situational awareness, urgency of the patient delivery, what selection of instruments, and how you are like communicating this to the your patient, you are engaging with this to your patient, and how you are communicating with the team member. So they are checking non-technical skill, your situational awareness, your communication with the team members, because you being a team leader, manage like taking leadership quality. And also they are checking how you are communicating those to this to the patient. So these skills they are assessing when they are giving you stations. Now, what are the types of forceps? Everybody knows these are non-rotational forceps and rotational forceps. So non-rotational forcep is outlet forceps Wrigley and low cavity forceps, and usually rotational forceps are keel end forceps. Okay, so I'll be explaining that in details. So these are the type of forceps. Everyone has to know this, and everybody knows this also. So this is the outlet forceps. Usually this forceps is called as a Wrigley's forceps. This is a low or mid cavity. So in low and mid cavity for they are using this forceps, and this forceps is the Neville Barney forceps. So this is a Neville Barney. Many time like you will be in part 2 question, answer is you have to put answer as Neville Barney if you think that you have to apply low or mid cavity forceps. Okay, and rotational forceps everybody knows this is keel lens forceps. So these are the pictures, and you have to recognize it also, because in the teaching stations and sometime in the viva station also they keep forceps. So if you're able to identify them, then you will be able to answer their questions. So it is real important to identify all type of forceps. Then if it is a teaching station, then you have to tell them your junior about the part of forceps. So these are the part of forceps. We are reading it from our UG days, nothing new about it. So these are the blades. Okay, this is the shaft of the forceps. This is the lock. There are different kind of locks are there. But more important is that, please all of you mute yourself. So these are the blades of the forceps. This is the shaft. Okay, this is the shaft, and this is the lock. Locks are of various types, but we need to remember that in like keel end forceps, it is a sliding type of lock. So I'll be showing that again. And these are the handles. So these are the part of forceps or the component of forceps. Now these blades has got two curve. One curve is this is the inside curve, and this is the cephalic curve. Cephalic curve allows blades to cup around the fetal head. So here the fetal head will come. Okay, so this is the cephalic curve, and this curve, this one, so this curve, this one is the pelvic curve. So why this pelvic curve is there? Because it is designed to follow curve of maternal pelvis. Okay, so when the rotational forceps are there, in those forceps this curve is not there, because the forceps has to rotate inside the pelvis. So if the curve is there, how the rotation will be possible? So this curve is absent in keel end forceps or rotational forceps. Okay, I'll be explaining that as well. Now these are the outlet forceps. So outlet forceps are, these are the Wrigley forceps. Usually these forceps, according to this RCOG guideline, these are when the head is already at perineum or station is more than +2, then you have to apply this Wrigley forceps. So in your part 2 questions, you have to see your station of the patient, what is given in the your question. If it is more than +2 they have given, okay, then your answer will go to outlet forcep or release forcep. So what are the criteria for outlet forcep? So that will be doing from that table that is given in the guideline. Now, this again, there low cavity forceps. What are the low cavity forceps? So these are when the station is in between 0 to +2. Okay, so if it is in between, if it is for low, it has to be at +2. So, and for mid cavity forceps, it has to be between 0 and +2. So this you have to remember, because when we read this table it sounds easy, but when we apply this to this table to answer question, then there occurs a confusion. So it is just a simple formula. So a forcep can only be applied if the station is 0 or less. So just see, if you divide that, then from 0 to 2 +2, the forcep, if it is applied, then it will be mid forcep. If at +2, at the level of +2 forcep is applied, then it is low forcep. And beyond +2 station, if the forcep is applied, then it will be a outlet forcep. So this understanding is all very important, because that will help you in answering questions. Sometimes confusion occurs in low and mid forcep. So if you remember this, then the things will be clear and easy. Now for the forceps, you cannot apply forceps without the prerequisites are there. So there is a mnemonic for this, that is forceps. So whenever you are doing teaching station, for part 3 people, when they are doing teaching station, so they have to part 3 teaching station, so you have to tell them prerequisite. So that time, you can't, you already know there is a table is there in the guideline about the prerequisite, but you can't explain so much of thing to your junior colleague. So you just can make the things simplify. You can just say there is a forcep, is a mnemonic is there. So these they clearly tells you the prerequisite for forcep delivery. So this is a forcep mnemonic that you can tell to your junior for the teaching station. So F is a favorable head position. Okay. O for fully dilated os. So os has to be fully dilated before you apply any kind of instrument. Before, if it is less than that, that will be the absolute contraindication. Then R will be the rupture of membrane, and C, contraction has to be adequate. If the contractions are not there, how you can apply it? Because mother also has to push, then the baby comes out. E for the engagement of head, that means uh, only less than 1/5 head has to be there. If it is more than that, then instrumental delivery is not possible. Adequate, P for adequacy of pelvis. As for stirrups or position of the patient is the lithotomy position. So this is a kind of mnemonic. If you tell it to your your junior colleague in the teaching station, that sounds a good, easy thing to remember. Because in the teaching station, you need not to show your theoretical knowledge. You have to just, give them attractive type of thing, and you have to make the things easy. Okay. Engaged head, okay, engaged head, they're not saying it at the station. They are just saying like from the abdomen, it either 1/5 or less than 1/5 is palpable. So if it is like that, then head will be either at 0 or it will be below 0. Okay, so this is the meaning of that. Hope I answered your question. Okay. Now, so when your junior colleague is coming to for teaching, first you will explain why you want to put forceps. So you have to tell them indication. So indication will, you can tell it from your guideline. Then you will tell some prerequisites. prerequisite you will tell from forceps. Then after that you have to take him, your junior colleague, to the whole process, how the forceps will be applied. Okay, you have to teach. So I have make a slide for that as well, but now I'm telling you, though everybody knows it, but I will be just doing it again, so that these are the few things, few words, or few things you have to teach to your role player, like your junior colleague in the teaching station. So once prerequisites are done, everything is done, then there has to have a there should be a mock application in front of the patient. Okay, so you have to use this word. So first we need to apply, and we have to do it in front of the patient or mother. So this is the mock application. With the mock application, you will be able to identify which blade is right side and which blade is left side. Okay, because in the forceps, this is a rule that we always apply left blade first. Okay, because lock is such that right blade has to come anterior. Fine. So always we are applying left blade first. So once the mock application is done, then only we will be able to identify which blade is right and which blade is left. So this is the mock application. Then this is the identification of blade. This is the left side of the blade. Then you will lubricate it. Okay, so they are showing that lubrication. Then this is again buzzword to use. So you left blade has to be held like a pencil handle by the left hand of the operator. Okay, and you have to hold this blade like that. So it has to this blade has to be parallel to the inguinal ligament of opposite side. So this is the left side of the patient. He is applying left side of the blade first, holding it in a pencil grip manner or pencil handle manner, and it is parallel. You can see that this is parallel to the inguinal ligament of this side. So all of this, like few things that you have to tell to your role player. Now when he is applying, so he is using his guiding it with a thumb. So okay, so it is guiding of the blade inside the pelvis by the thumb. Okay, so all these few things you have to tell to your role player. Then once the blade is applied, so this is the correct position where the one blade of the forceps will lie. And for clinical purposes, you will find that this part of the forceps will appear horizontal. So that will be an idea that the correct that left blade has been applied and it has been in a correct position. Then either if it is applied in a correct position, even you can leave it also, so it will not rotate, or it will, there will be no problem, it will be in this correct position, lie down. Otherwise you can take the help of your junior colleague, so, or anyone, who will hold this blade in this position. Then similar manner you have to apply right side blade. Now he is holding right side blade in a pencil handle manner, and now it is parallel to the inguinal ligament, opposite inguinal ligament, that is the right side left side inguinal ligament. So this is the right blade held with the right hand, opposite to in a position, so it is lying opposite to the opposite side, it is lying parallel to the opposite side inguinal ligament. So this all things you have to tell it to your role player. Then once it is put inside, so it will be again guided by the thumb. Then if once it is applied, and it is applied in a correct manner, so you will see this is the right blade and it is locked from above. Therefore it is a dictum also, just to remember in our head, that right blade comes from above. Okay, so this is the right blade, it is coming from above. Therefore we always apply left blade first. Fine. Now this also you have to tell it to your role player. So if the forceps are applied, so before, this is again a patient safety point. So once you have applied a forceps, it has to be in a correct manner, correct application of forceps has to be there. If it is incorrect, or you have not applied it rightly, in that position, it you will be, you will not give any kind of traction. So this is the main big safety point, and you have to, with the emphasis, you have to tell it to your role player student, that forceps, so this is the few things. Forceps should not be forced into the position. So if it is applied in a correct manner, so locking will be very easy. Okay, if you have not if it is not applied in a right manner, so this will not lock. Okay, so from this position, easy locking or difficult locking, you will be able to find out whether this forceps has been put in a right manner, or whether it is, any problem is there. Then this is a sagittal suture. Okay, so it has to be in the midline. So you see this, a forceps blade has been applied and it is almost in the midline. Fine. Third thing, that both of the blade, they should be equidistant from the sagittal suture. So this is a sagittal suture and they are equal. Both of the blades are at the equal distance, and you will be, one fingertip can be inserted in between fenestration. So these are the fenestration of blade. Okay, and this is the fetal head, and if they are rightly applied, so you'll be able to put one finger here. So these are the few things, these are the few, or you can say that these are the few safety checks that you will do before you apply for traction. So this is the important safety points, in the exam you have to tell it to your role player student. And these points are still very important in your clinical labor wards also. So whenever we are applying forceps, we are looking for this correct application. At least practically we look for easy locking, and also we look whether the sagittal suture is midline, and also we check for this finger trip. So these few things even we are doing in the clinics also, sorry, in the labor ward duties also, when we are applying forceps. So this is real important. It's not for the exam, for our labor wards forceps application as well. So this is really important to put in the answer. Now, once they have that correct application is then has been done, then you are ready for traction. Then the traction can be applied. So before you apply traction, you have to make it sure that this contraction has to be applied along with the mother's contraction. Okay, so with the contraction you will apply forceps. So usually it follows the J shape or direction of traction. It follows J shape of maternal pelvis. So first it will be downwards till the head crowns, then gradually it will come upwards. Okay, so this way this will so this is it follows J shape curve of maternal pelvis, and you have to use this word to your role player, and you have to show simultaneously also. So what are the words I'm using and I'm explaining? Exactly same kind of words you have to use, and so you'll be able to uh, um, uh, explain it to your role player, because it comes as a teaching station, and you have to practice in the dummy pelvis, so that um, because while doing exam you have to speak and you have to show at the same time, so that kind of practice is required. Okay, so you have to do that as well. Now, so this is the explanation. Now, what are the things in part 3 teaching station that will come as a answer key? You have to bring those in the station to gain marks. Okay, so you can say first your will be your introduction, after checking of agenda, and after that you always tell contraindication. Then you start with the prerequisites. So prerequisite, either we have discussed in a forceps. So my voice is there or not? Hello, my voice is there?
Yeah, clear and there.
Okay, fine. So prerequisites, either I have just explained like forceps, or please all of you mute yourself, otherwise there will be a problem. Fine. So, or in another manner, what you can remember, prerequisites as ABC. What is A? There are so many A that will help you remembering all of this. Speaking all those words will give you marks somewhere in safety or in applied knowledge. First, A, address to patient. That means you have to take consent from the patient, and also you need to document it. Make it sure that mother has analgesia. You have to follow aseptic procedure. You have to do abdominal examination. Okay, so these are all A's that you have to bring in the answer to gain marks. B, for bladder has to be empty. You have to speak this is the main this is a safety point. You have to speak that mother's bladder has to be empty, because this will give you marks. On full bladder nobody can apply forceps, fine. Cervix has to be fully dilated, contraction has to be there, and there has to be communications. So again you have to bring that whom you will communicate. You will communicate to anesthetist or anesthetic team for pain relief. You will communicate to midwifery team for help. You have to communicate with your neonatal team for resuscitation. So if you do, you are putting all the teams in the answer, that will give you marks in communication with colleague domain. Therefore understanding of this exam is important. So what I'm speaking, every line, every bit of it, you have to bring in the answer to gain marks. Now this will be the sequence that you have to tell to your junior colleague to gain marks. Everything you have to bring in the picture. So you have to explain about position, lithotomy position, mock application. Apart from this, you have to say about the trolley check. So instrument check is also important. Then this is the just sum up what I just explained to you. So for left blade, held in left hand with pencil grips parallel to the opposite side inguinal ligament. Then right hand will will be introduced into the vagina, and blade will go inside, and with the guiding of the index finger or thumb, it will put inside the left side of the patient. Then say similar process will be repeated for the right handed blade or right side blade. So if you have put them very fine, so handle will lie in near horizontal plane, and their handle will look at the they will look at the ceiling, so it will be near horizontal. They will not be at any angle. So this will give you an idea that your forceps is rightly applied. Then you have to do all the checks. So you have to say to the role player, we need to do all safety checks, at least one, two, or three few things you have to explain. Then sometimes they apply horizontal traction with the right hand, so that this maneuver is a Pezot's maneuver. So usually it is designed so that it will bring fetal skull down, the symphysis pubic arch. So this is written in the in the basic practical skill box. Therefore I have put it here. But this Pezot maneuver, it appears to be a bit complicated. In the role player station, you can miss this point also. Apart from this, now the application safety checks are done, blades are applied. Then when the patient is having contraction, then you have to assess for episiotomy. Then you can say that we need to assess for episiotomy. But in forceps, 9 out of 10 we need to give episiotomy. And it is, you can also add one point that according to this new guideline, it is given at 60-degree angle. So all of this will give you marks for knowledge and safety. Then once like um, once all this episiotomy done, then when the head is bent and contractions are there, then in J shape the traction will be applied after safety checks at the J shape manner. Okay, and once the baby's chin come into sight, then you will remove the blade. So you have to say this. Once the chin is appears, after giving traction, we need to remove the blade, and removal of the blade has to be done in reverse order. So you have to speak this word. We need to remove. It has to be done in the reverse order. That means right blade should be followed by left blade. Then now the forceps application is done. So then you have to just wait for baby's head to restitute. If any cord is there, then slipping of cord will be done. Then the baby will be delivered with the lateral traction, lateral fraction. Then once the baby is delivered, then baby would be handed over to the neonatal team or pediatric team. And in instrumental deliveries, usually cord blood gases are done. Then this completes the baby part. Then you are delivering this patient, then just say that we need to do the active management for third stage of labor. After that, we have to check for tears. If any tears are there, we need to repair them. We need to repair episiotomy, and we need to see whether there had been any bleeding, or we need to arrange accordingly. So now you being a safe person, because you are doing every work systematically. You are worried about mother, you are worried about baby, and you are doing everything. Then at the end, you will say, once every repair has been done, then we have to do the swab counts. So WHO safety checklist, you have to bring another buzzword in the answer. Then say something about documentation, because this operative delivery documentation form is there. Towards the end, you will debrief to the mother in the birthing part. So this, every part of this in a sequence, you have to bring in the answer. Apart bringing all safety points, highlighting all safety points, that will give you answer for the teaching of the forceps station. Okay, so you have to bring all the answer points, and also you have to like show how you will apply the forceps. Then you will get 10 out of 10. So anything that's all about the outlet forceps or release forceps. So anything that is not clear, you people can ask me. Any questions? Any question? Okay, no question. Good. So I'm doing my job right. Okay, so now comes the rotational deliveries. Rotational deliveries could be three types. It could be three types, and one time in RCOG station has come there, they asked about the rotational deliveries. But so you have this, whatever the knowledge I'm putting here, I think that will be enough to answer that station. So there, so when how many types rotation can happen, so you have to speak about that. So there could be three types. One will be forceps rotation, then it will be Ventouse rotation, and another will be manual rotation. Though manual rotation is these days not done, but again, if you are putting answer, so you have to at least speak about that. Okay, but nobody will be going to ask you how it is done. So but when you are telling them about the rotational delivery, so you have to say it three times. So this is the, so we'll be discussing all. So once is the forceps. So first is the forceps we will be doing. So this is the forceps, and this is the key length forceps. Okay, so I have heard one time in the exam, they have RCOG course, they have given key length forceps. So you have to know this forceps. So I'll be explaining. And key length forceps is the forceps that used for the rotational forceps deliveries. Now, so why we are using key lengths? Because whenever this rotation is done, then if the manual rotation is done, so baby will rotate back again. So therefore, with the key length forceps, this like problem of rotating back into the mal position is less. Okay, second, uh, why we are worried that whenever the rotation is done, first we have to disimpact. So with the manual rotation, chances of cord prolapse were more. Then complete this sometime with the manual rotation, either it will be it will be too high, or it will be so that it will be very difficult, because if it is too high, so it will be very difficult for hand to go. So because of all these reasons, a key length forceps or forceps rotation is preferred, and that is better. But it do have a expertise. It is so difficult, only expertise can do rotational forceps. Okay, and it is so much of rotation, disimpaction rotation is required. It cannot be done in room, it has to be done in theater. And also patient has to be in regional anesthesia, or usually it has to be in the regional anesthesia, so it cannot be done in the room. So if it is there, a patient has to be shifted to theater for rotational deliveries. Now this part is important because I think this will be asked in the exam. So in the keel and forceps, this I have explained again also. So this pelvic, this is the pelvic curve, but in this keel and forceps this pelvic curve is not there because we have to do rotations. Okay, so now you can see, so this is the keel and forceps blade where this pelvic curve is not there, or it has got minimal or no, almost nil pelvic curve. Then again, this is again about its handle. It do have a sliding lock, so you can, these blades, they can be slided like this way. You can just see like this, so they can be slided. And why they have got sliding lock? Because sometime when the head enters in the pelvis, usually it enters in the mm, when usually it enters in transverse diameter of the inlet, but sometimes it could be slightly tilted to anterior, or it would be, could be slightly tilted to posterior. So this is called as asynclitism. Okay, and to correct this asynclitism in the pelvis, if they are doing rotation, so they have to do that, they have to do that correction, and for that correction they have got a sliding lock. So this is the reason the sliding lock is there. Then towards the end of this, there are knobs. You have to, you know already, you have to remember these knobs. These knobs are usually, they are lying towards the occiput, and whenever the rotation is done, it is done towards the occiput. So this knobs will guide uh, where the rotation, what type of rotation is there, or what we are doing. So they act as a marker. So therefore these are the few things, these are different in this rotational forceps or the Keeland's forceps. Okay, so this minimum things you have to know because this will be asked in the exam. Then usually where we apply this forceps, we apply this forceps either in the for the, if the rotation is required, there could be either occipito-posterior position or occipito-transverse position. So for Keeland blades application, usually there are two types. Okay, one is direct method, another one is wandering method. But for occipito-posterior, there is only one method of application of blade, that is direct application. Okay, so direct application is, of the blade is done if the head is in the occipito-posterior position. So what are the steps? Application of blade in occipito-posterior will be same exactly what we did for the occipito-anterior. Hardly, any changes there in application of blade. So first, again, first step will be the insertion of blade. So left blade will be inserted after doing mock application, and we need to make, but one thing is there, we have to make it sure that that knob what is there in the keel and forceps, that should point towards occiput, where the occiput of the baby is lying. Okay, similarly, after left blade is applied, right blade will be applied. Then with the sliding lock, if any kind of syncretism is there, then that will be corrected, then the rotation will be done. But before rotation, whatever will be the type of rotation, slightly these blades will be pushed upwards, that will help in disengagement of head from the maternal pelvis, because head has to be disimpacted only, then only rotation is possible. So after disimpaction of the head is done, then knob will point, and at the, with the shortest possible route, uh, fetal head will be brought to the occipito-anterior position. And once rotation from occipito-posterior via shorter route to occipito-anterior is done, then a rest application of blade will be same what we did for the occipito anterior. Okay, so only this thing is different in occipito posterior. So you can divide this into three parts as I have put in the slide. First will be insertion of blade. That will be assembly, mock assembly in front of pelvis. Apply left blade, apply right blade. Make it sure that the knob will lie towards the occipit. Then make it sure for second part will be rotation. Do disengagement or disimpaction. Then rotate to the shortest possible route to occipito anterior position. Make it sure that that knob will always be guide and that will point to occipito or toward the occipit of the baby. Then rest traction part will be the same. So this is application of blade forceps for a direct application of blade when the baby is in the occipito posterior position. Occipito posterior also comes as a teaching station, and there you have to explain about the normal route, what the three routes are there. Then you have to explain about the forceps. So I'm explaining here only the forceps part. So this way, this much you have to speak about occipito posterior direct application of blade in occipito posterior position. Now you can, I have tried to put some picture. So with the knobs facing towards occiput, so blade will be applied in the same manner. So this is the occipito posterior position of the baby. So first they are applying left blade, then they will apply. So these are the same pictures. So first they will apply this left blade. Okay, so this is the, they are again same left blade is being applied. From here they will apply right blade. Then if the blades are applied in a correct manner, now you can see they will lock with ease. This is again the safety check. Okay, after safety, this safety check is done, then pointing this knob, so this is the knob, in between contraction they will rotate it to the shortest posterior shortest route. So this occiput that is lying on the posterior, it will come anterior. Okay, so this is the occiput lying here. So with the rotation that is usually done in between contraction, this head will come here and it will be in the occipito anterior position. Then direction of traction will be the same as what we did according to the J-shaped curve of the maternal pelvis. So this much you have to know about the occipito posterior position application of blade, that is a direct application. Is the thing clear? Is it clear?
Yeah, it is clear.
Okay, now next come the occipito transverse position. In occipito transverse position, when the rotational delivery has to be done, so two type of application can be there. Either it could be the direct application or it could be the vendoring application of blade. Okay, so these are the two ways of application, and I would be explaining you both. Okay, so a direct blade. So now see, I try to put pictures here. So this is first, first there will be again um, mock application of blade has to be there in front of maternal pelvis. Then need to identify which blade will lie anterior and which blade to lie posterior, and how it will be done. When you are doing mock application in front of the pelvis, you will always see the knob. This knob will always lies towards the baby's occiput. Okay, so this is the one guide only in this kind. So once the anterior blade has been selected, so in direct application, this anterior blade will be directly pushed so that it will lie be under the symphysis pubis. Okay, so this is the direct so now you can see here lying the blade. So this is the occipito transverse position. This is the position of blade already they have applied. So it is lying it between the baby's head and also maternal pelvis or maternal symphysis. Okay, so this is a directly they will apply into this position. So this is a direct application of anterior blade in case of occipit transverse position. Now similar way, so once anterior blade they have nicely positioned, they will put the posterior blade, and posterior blade will be put in the sacral halo. Okay, so this is a sacral halo. Then they will lock this blade. If any kind of like if the blade asyncretism is there, so it will be then corrected. So once the blades has been nicely locked, then in between contractions, when the uterus is relaxed, so they will be rotating it so that this occiput that is lying in the transverse direction, so it will come to the anterior position here. Okay, so this they will be rotating like this. So then the rotation will be done. Now, this is again, now you can see this is a direct application in case of occipito occipito transverse position. So this is the occipito transverse position of the baby. So they are directly applying anterior blade. Then in a posterior blade will be in the sacral hollow. So they are putting posterior blade in the sacral hollow. Then if they are correctly, if there had been no problem, and blades are rightly applied, so they will lock with the ease. Now you can see these blades are nicely locked. So this is the picture here. Then once the locking is done, then then the rotation has to be done. So this rotation, before rotation again they have to disimpact the head. Then in between contractions, when the uterus is relaxed, rotation has to be done with so that this occiput that is lying in the transverse direction, so the rotation will occur and it will lie in the occipito anterior direction. Once the baby has come in occipito anterior direction, then rest of the delivery will be done with the way we have done with the occipito anterior delivery. Look scary. Injury to ears. Yes, it is scary. Rotational deliveries are scary only. With the forceps, this is quite scary. But we are not doing, in our labor ward. I don't think so. We are anyone is doing. If this kind of situation is there, we already send the patient for section. But for the sake of this exam, answering question, we have to know this. So this is just for theoretical thing for the exam to pass that station. That's all. Then so this was the direct application. Okay, so this is the direct application. This is a picture how the things will go in direct application. Now another, in occipito transverse position, there is second method of application is also there. So that is a wandering method. In wandering method, you know what they do, they put anterior, first they will be mock application, then anterior blade they will put in a conventional manner, the way we were putting left blade for occipito anterior position. Once they have put it, then they will vendor the blade over the face. Okay, so this line I have directly taken from their video, so you have to speak same kind of things. Okay, so it is that after putting anterior blade in the conventional manner, so it is vendored over or guided over the baby's face. Okay, so once it is so that after guided, it comes under symphysis pubis. So you are putting blade here in a conventional manner, what we used to put in Latin in the occipito anterior. Then you are vendoring it or you are guiding it so that it is lying below the under the maternal symphysis pubis. Posterior blade will come directly into the sacral halo, and once the application of blade is done, then there will be rotation. Okay, so these are the two methods for occipito transverse position. So one was the direct application of blade, and the second method is wandering application of blade. It is difficult and scary, but we have to do just to pass station, not to do in our labor wards. Now this way the rotation happens. In once the blade application is there, after blade application always head has to be disimpacted from the pelvis, so that will create kind of free space. And whenever this disimpaction is done, after that rotation has to be done. And rotation usually it is done in a between contraction when the uterus is relaxed, and you need not to apply too much pressure for rotation, only fingertip pressure you have to apply. So you have to use this word in the exam. Then once the whatever the rotation will be guided by the knob of that is lie, knob has to be towards the occiput, and with the shortest possible route guided by the this knob, rotation has to be done. So once the rotation is done, and with the rotation, head has come to occipital anterior position, then all rest of the traction will be done as the in the J following the J shaped curve of the maternal pelvis, and rest steps of the delivery what we did for occipital anterior, it will be the same. So this is rotational forceps for occipito posterior position, direct application, occipito transverse position, two application, one was direct and another was venting method of blade. Then in both of them, after correct blade application, there has to have a rotation. So is this appears to be a bit difficult, scary. I try to make it as simple as possible from my side. So if anyone has to ask question about this rotational forceps, can ask me. In this much, with this much knowledge, you can easily pass that station. Any question? Any question? Am I audible? Okay, any question? No question. Okay, so that this much you have to know about the rotational forceps. So after forceps, we have to go towards Ventouse. So Ventouse, different kind of Ventouse are there. So the metal Ventouse cups are there. These are the celestic cups are there, and this is the kiwi cup is there. But most of the time, these days using is the kiwi cup. So there will be I'll be there will be discussion about this kiwi cup. So when to abandon the procedure, that will be doing from the guidelines. So I have not put it here. So this is all about this Ventouse, and you have to know the everything, all buttons of the Ventouse, because you have to tell this to your role player colleague. So this is the vacuum cup. Okay, so this is the suction tubing, and this is a traction force indicator. And mainly you have to know, so this will tell the vacuum level. Usually we start vacuum at the 0.2 kilogram per meter square, and if when you increase it to 0.8, so it will lie at the green zone. So if your pressure is going more than green, or it is reaching red, that means you have put excessive pressure. So this is a safety point. Okay, so you have to be in the green zone only. So this part is important, you have to explain this to your role player. And this here you will put finger, and this is the hand piece. With this hand piece, vacuum can be created. So it is a handheld device. Okay, now one important you have to tell that this part here, once the baby is delivered with a vacuum, here there is the button is there, and once this button is pressed, then that will release the suction. Because once the baby is delivered, you have to release the suction. So this is the button lying here, that you have to explain to your role player. Okay, so this is a traction force indicator, but it is never, we are not seeing it, and it require, we need not to know much about it. Main important what we have to know is this. So this much explanation you have to do to your role player also. Then this also you have to explain to your colleague, so where you will apply it. So you will usually apply it as a flexion point, and you have to show them where is a flexion point. So it is located on the sagittal suture 3 centimeter in front of and posterior fontanelle. Okay, so you have to explain them. So this is the posterior fontanelle, and on the sagittal suture you have to it is the point lying 3 centimeter in front. So this is the flexion point, you have to tell them. Now there are few things situations where Ventouse cannot be applied. Okay, so this also again a safety point that you have to tell to your student in the teaching station. So if you don't know what is a position, undetermined position, you cannot apply Ventouse. Face you cannot apply, absolute contraindication. Breach you cannot apply, and excessive premature baby, like less than according to the new guideline 32 to 36 weeks, extreme caution, or you need not to apply. Why? Because fetal if the vacuum is created, then that will lead to vascular injury, and there will be this subgaleal hemorrhage, and all this stuff will happen. So in prematurity it is not applied. Then if any fracture predisposition is there, osteogenesis imperfecta, or any contraindication for maternal active pushing. So all these are the things where Ventouse will not be applied. So we'll be doing this in the guideline also, but this at least few of the contraindication you have to tell to your junior colleague. So this is the application pictorial explanation for Ventouse delivery. So this is the first we need you have or everything you have to explain to your role player. So first, what will be the first part? So you have to position the cup in the flexion point. Then once the cup is correctly applied, then you have to do the pressure. So for once you will apply the cup, then increase the pressure to 0.2 kilogram per centimeter square. After this pressure is done, first safety point, you have to rotate your finger or around. Why? Because you want to check for maternal tissue entrapment, because if any maternal tissue is entrapped, you will not increase pressure to 0.8. You will then reassess and reapply it. So once you have checked for maternal tissue entrapment, then pressure can be increased to till 0.8. Okay, so once now the cup application has been done, so usually when the one finger is applied at the this part of the cup, why this is applied? Because this will help uh, if any kind of this cup detachment is there. Then once after application is done, whenever the mother like patient is having any contractions, synchronous with them, you will this direction of traction, first it will be in downward direction, then gradually it will change to upward direction. So the direction of traction will be downward, then upward. So this will be again J-shaped curve of maternal pelvis. Then when the head is about to deliver, then or when the head is crowning, so you know you need to assess whether episiotomy is required. If it is required, then you have to give it. Otherwise you will change the position of hand so that perineal protection will be done like this way. That will decrease the any chance for any sphincter injury. So this you have to speak, that will give marks on the safety. And once the head is delivered, so once it is done, then head has to be delivered not with a rush, it has to be delivered in nicely controlled and slow manner that has to mimic a normal birth. So these are the steps, all the steps you have to speak to the role player in the teaching station. Okay, so this is the answer key. So that was the explanation. And this is the answer key to the Ventouse delivery station in part 3. Okay, so from top to bottom you have to speak about everything with putting emphasis on the safety all the time. So first of all, again, this is the ABC. First, you need to rule out all contraindication. You have to be a safe doctor. Then you need to address the patient, explain the procedure, take consent, make it sure she had analgesia, do abdominal examination, maintain asepsis all the time, make it sure bladder is empty, cervix has to be fully dilated, contraction has to be there. You need to make it sure that you have to determine the baby's position and also station. Trolley has to be there, and there has to be exit plan. Okay, if the Ventouse fail, then after these are the checks are done, then you are ready to apply it on the flexion point, like what I explained you. Check for maternal tissue entrapment. After that, check assess if the episiotomy is required. Then after that, like whenever after application of the cup, whenever the patient is having contraction, then in the you have to give traction in the simple J-shaped curve of the maternal pelvis. When the jaw is visible, then you have to remove this instrument by putting that button for suction off. After that, you have to wait for restitution of the baby, deliver the baby, hand the baby for the pediatrician for cord blood gases. Again, then you have to assess, do the active management for third stage of labor. Need to repair if any tears or episiotomy is there. Need to check for epistosis, hemostasis. Need to do the swab counts. Then you have to document and debrief. Again, you have to halt if there had been no descent with 3 contractions, and if like cup pop off is there more than 2 times. So this will give you marks in the safety, and you have to speak about everything in the Forceps teaching station. Any question about this? Any question? Any question? Okay, so after that, little bit you have to know about the rotational Ventouse delivery, because they are not asked in the exam. But if you're telling them about the rotational delivery, so second after forceps, second will be rotational Ventouse. So this is a rotational Ventouse. It is the on the tubing of the Ventouse. So you usually there are 2 marks are there. One is at the 6 centimeter and one is at the 11 centimeter. So if like if you apply, if the it is applied on the flexion point, then if it occipito transverse position, so it will be at 6 this mark. And if it is occipito posterior, that means you will be applying it to to on the towards the this point. So then at the level of the vagina, this part will be 11 centimeter. So again the same way. So in the for the occipito posterior position, if the cup is this is occipito posterior position. Okay, so sorry, this is occipito transverse position, this is occipito posterior position. Now occiput is lying posteriorly. If the cup is rightly applied, so this 11 number mark will be visible at the vulva, or it will be visible at introitus. So by just whether you have applied this correctly, you'll be able to assess from this number only. Then in occipito transverse, because you will apply this in occipito transverse position, cup is usually applied in the midline. So this is the occipito transverse position. It is applied uh, on the midline. So you will see that this mark will come at 6. Okay, so this little knowledge is required because it is not asked in the exam. Then for the once the correct application is done, you need not to do anything. Um, it will self rotate by itself. Your direction like direction of pull will be the same. So once the cup is in direct position over the flexion point, vacuum will be created. Now you have applied it correctly. So you need not to do anything by holding the cup. You need not to rotate or twist. It will be self. Okay, it will be self correction will occur. So as the head flexes and it descends to pelvic floor, there will be auto rotation or auto this way it will occur by itself. And your direction of traction and everything, it will be same. So it will be just self correction, only it has to be applied in a right manner. So this much knowledge about rotational Ventouse is required because it is not usually asked in the exam. And if they are asking in the exam, then rest, it will be the same what we did in the occipito anterior position. Only this much knowledge you have to speak, where you will apply and where this marking will lie at the introitus. Okay, and there will be no rotation or or any twisting is not required. So it will, or when a head will come down and onto the pelvic floor, so there will be auto rotation. So this much about rotational delivery. Then again, it appears to be good mnemonic. In the answer key to the forceps or vacuum delivery, you can just like if you want to, this may be the another manner to explain your role player. So that A to J mnemonic is there. That is a for vacuum delivery. This ABC we have already done. D will be determining of position. E will be exact plan. F will be fontanelli to check position. G will be gentle traction. H will be halt. Okay, if there had been no progress with 3 poles. And I for incision, and J remove the instrument when jaw is visible. This much you have to know also if anyhow your role player ask in the exam, or you can put in the exam answer key also, though it is a repetition of the same what we did before, but it is a mnemonic that you need to know. So any question about it? Any question?
Excuse me, ma'am.
Yes. Yes.
So, ma'am means rotational Ventouse. So, ma'am means in rotational Ventouse delivery, there is as such nothing new. It's just that
No.
we will recognize the position of the cup.
Yes. Yes.
Hello.
Yeah. You have to do
Okay.
nothing.
So it is okay. Fine. Nothing is there. Okay,
Yeah.
fine. So it will be in the usual manner. It's just the
Yeah, it
one
will be.
point of tubing length of 11 centimeter we need to add.
Yes.
Okay.
Okay. So last will be, so we have done forceps rotation, vacuum rotation, and now manual rotation. Manual rotation, not much knowledge is required. Only just I'll be showing it you from the pictures because it is never asked in the exam. Okay. Only you have to speak that, yeah, 3 types of rotation. So just you can see it from the picture, but it is not important anywhere. So first the hand is inserted, like whole of the hand is inserted for manual rotation in the vagina. Then it is held in a manner. So this thumb will lie on the anterior parietal bone. So this is the parietal bone, and your finger will lie on the posterior parietal bone. Okay. Then once positioning is done, then disimpaction of head will be done. Okay, while disimpaction you have to be very clear, because if you are completely disengaging, sometime cord prolapse can happen. Okay, so you have to make it sure. Then it is with a then in between contractions when the uterus is relaxed, So with the shortest posterior route, this occiput is rotated to anterior. Okay, so this is rotated in this manner. Then once it is rotated, so this will be rotated. Once it is in a right position, then forceps will be applied, and delivery will be like the what we do. Forceps application will be same what we do in the occipito anterior. So this is the sequence of manual rotation. But again, no need to remember or no need to practice also, because it is never asked in the exam. So that's all about part 3 stations or teaching about rotational. Now I'll be moving to guideline. So anyone, if you have got any question, can ask me before I move to guideline. Any question?
Dr. Priyata, please explain again
Yes.
wandering method.
Wandering method. So this is the wandering method. So it is the second type of application for forceps application if the head is in an occipito-transverse manner. So first there will be mock application in front of maternal pelvis, identification of anterior blade and posterior blade, then selection of anterior blade. After that, this anterior blade will be put into the maternal pelvis in the same manner what we are doing conventional forceps. Okay, so they have applied this blade. Then in this position, now it will be in the left side of pelvis what we do in conventional forceps. After this application, this anterior blade is applied in a conventional manner, then it is wandered over the baby's face, or you can see another word, it is guided over the baby's face. So this anterior blade will lie over fetal face and under the maternal pelvis. So if the position is right, so it will lie in between over the below the maternal symphysis pubis over the baby's face. And so this will be the this is the wandering method for application of anterior blade. And posterior blade will be put in the sacral hollow. Okay, so they will put in a sacral hollow. After putting posterior blade in the sacral hollow, then they will lock it. If any asynclitism is there, they will correct it. Then guided by the knobs using fingertip pressure, they will be rotating it so that with the easiest possible shortest route, so that it will become occipito anterior. Is it clear?
Yeah, it is clear. Thank you.
Okay, so now I would require one volunteer to do the guideline. So anyone to volunteer? Because why should I keep on speaking? So I will be asking questions and answer will be in front of your screen only. So anyone who would like to speak? No one wants to speak. One person has to speak.
Okay.
Okay, good. Fine. So what is the incidence of assisted birth?
Incidence in UK between 10% to 15%. In all the
Yes.
guideline, up to 13%.
No, see, what we have to learn, it is according to this new guideline, because you will get question from this guideline only. Because in TOG and in
Yes.
previous guideline and there are a number of places, different percentage is there, but for the purpose of this exam, no confusion, 10 to 15%, fine. So how
Okay,
much
okay.
there in the primary, what will be the incidence
1
in
in 3.
primary 1 in 3?
1
So
in
this is
3 in
newly added.
primary. Yes.
Yeah, this is the newly added in this guideline. So what can happen? So you can get question from this line also. So subgaleal hemorrhage, intracranial hemorrhage, skull fracture, even perinatal
Yes.
death can happen. Okay.
Y-
So these are few things because you may get this in SBA.
Yes.
Yeah, so it is real important. So what do you think that so this is again a question asked. So what can reduce the need for assisted birth? This is common question,
Can,
you know.
yes. Common and recall questions. Continue support.
Yes, continuous support in the labor reduce
Yes.
this. And what about
And
what happen in
delay
epidural?
epidural. Yes. Delay epidural 1-2 hour better for patient. Because if we give epidural anesthesia early, increase need for operative vaginal delivery.
Yes. So epidural analgesia, usually it increase the need of assisted birth. Why? Because the patient feel relaxed, so much of contractions are not there. So epidural analgesia usually increase, okay, but
Yes,
it does
increase.
not depend upon type of anesthesia. So if you are doing epidural, if you are doing combined spinal epidural, so there is no difference. It does not vary with the anesthetic technique.
Yes.
Okay, so what do you think if it is given, if a patient is there and she's 3 centimeters, she's asking for epidural analgesia, do you think that there will be increase in assisted birth?
Not increased risk of assist.
Yes, so this is a new thing added in the guideline, you may be asked in the exam. Okay, now two
Yes.
type of things can be there. Patient is in epidural. So what type of position should be there that will increase chances of vaginal birth? So position in epidural,
If epidural anesthesia, lying down lateral position. Without epidural, upright or lateral.
yes. So this, this you have to remember because now they have put new thing in the guidelines. So they will ask this question. Okay, it is
Yes.
important now.
2 questions.
Now
Yes.
now there are two questions, and unless you do it by heart, you will be get confused in the exam. So it is without epidural, it is upright and lateral. With
Yes.
using epidural, down lateral. Okay.
Yes. Yes.
Yeah. So what do you suggest, delay in pushing will be of help in nulliparous women?
Recommended delay pushing for 1-2 hours in Nalibara.
Yes. And
Reduce. Yes.
yes. So what do you, this we have discussed. So any particular type of regional anesthesia technique will not, decrease or reduce the incidence of assisted birth. So what is there say about oxytocin? Did the routinely oxytocin should be
Not recommended. Insufficient evidence.
yes, it is important for part 3 people because this role player will ask you. So what do you think, routine prophylactic manual rotation should be done in second stage of labor?
Also insufficiency evidence to recommend
Yes.
routine.
Yeah, so these 3 lines they have added new in the guideline, important for both 2 and 3 people because role player is going to ask 3 questions. Okay, so
This is very important. Yes.
yeah, this is very important. So usually if the caput is there, so we will think that head is vertex is lower, but ideally it gives false impression. But there is one position where
Deflect.
yeah. So this is the one. There will be one exception. What is that accepted position?
Exception deflexed occipito-posterior position.
Yes, and you will get part 2 people will get this in their exam. So this is the exception. Okay. Now this part
Yes.
we have to this part we have to remember by heart. Because they
Yes.
have this classification has been changed in this guideline. Previously high was also there, but now they have removed that high. Now they have put it outlet, low and mid. So what are the criteria for outlet?
Okay. Outlet fetal scalp visible without separation, the labia. And
Yes,
fetal scalp reach perineum.
yes,
Rotation not exceed less than 45.
less than 45.
Outlet.
So these are the
يعني
criteria.
outlet at perineum.
Yeah.
Head
So
at perineum.
yes. So usually outlet forceps will be the answer when you will
Uh,
find station more
Wrigley
than
forceps. Outlet forceps. Here you will use.
yes, more than +2. So in your station, you will find at the perineum or +3 station. Then your answer will be outlet. Okay, what is the criteria for low forceps?
From 2 centimeter to perineum, but not reach perineum. Non-rotational or rotational we use.
Yes.
Less than
So
45 non-rotational, more than 45 rotational.
yes,
But I want to ask one question. +2, if mention any questions, +2, it means low or mid cavity? +2, if written
+2 is low.
head low.
See,
Okay.
+2 is low. More than +2 is outlet. Less than +2. Less than +2. That means 0 and +1 are mid. It is
Yes.
they have
Okay. Okay. Okay.
just remember this +2. So
Yes.
low will be +2. If it is more than +2, it is outlet. Less than +2, it is mid. So now
Yes.
the things are so because when you answer part 2 questions, the things will really become difficult, confused between low and outlet. But if you remember like this, then it will stick to your head.
I have some questions written +3. +3 outlet.
+3 is outlet.
Yes. Okay. Thank you.
Yeah. So now, according to this guideline, only one absolute contraindication is there. If it is not fully dilated, so that is a contraindication.
Bleeding disorder.
Yeah, uh, uh, bleeding disorder is not absolute contraindication because
Relative contraindication.
relative contraindication. So absolute contraindication is only one when the prerequisites are not fulfilled or it is not completely fully dilated. Okay. All other
Yes.
contraindications are relative contraindication. So this question may be asked in the exam. Okay. So
Yes.
this we have done suspected bleeding disorder and predisposition to fracture, that is osteogenesis imperfecta. So these are the relative contraindications. Okay, and if the blood-borne infection HIV and hepatitis B is there, that is also a
Not absolute.
relative contraindication.
Yes.
Okay, now if a question comes like if you have just done a fetal scalp sampling, so can you apply forceps ventouse?
Yes, we can. Not
We can,
contraindicated.
not
Yes.
contraindicated. Yes, and this is very important for part 2 and part 3 people. You have to do it by heart. So in between is 32 to 36 plus 0. If this time is there, so vacuum should be used with a cautious
Caution.
or it should not be used. Okay, so
Yes.
in part
Less
3,
than 32. This is new. Less than 32 weeks. Avoid. Between 32 and 36 with caution.
with
Before
caution.
34 weeks. Now new 32 weeks.
Yes, now 32 weeks. So this has changed and you are going to get question from there. Part 3 people will
Yes.
get a station where they will judge this. So it is important. Okay, so now what are the medical condition? Hypertensive crisis, myasthenia gravis, and spinal cord injury. So now they have seen forceps and vacuum absolutely contraindicated if it is for less than full dilatation of cervix. So there's only one contraindication, absolute contraindication. Okay.
Yes. Vacuum
Now this
contraindicated with face presentation also.
that vacuum is contraindicated. So I have just discussed the absolute contraindication of relative contraindication for vacuum. So vacuum is contraindicated in face. Even the breech also you cannot apply it.
Yes.
But the forceps can be applied.
After coming head, yes.
Yes,
Forceps.
and these bleeding disorders like
Really good.
thrombocytopenia or osteogenesis imperfecta, these are relative contraindications. So in your
Yes.
exam, if you are getting this kind of questions, consideration for even though there are relative contraindication, but still low forceps can be applied in this condition
Yes.
also. Low forceps can be applied. Okay, so this
Yes.
is real important. So what are the indications? So fetal you already know. So anytime if you find your pathological CTG is given in the question, and anytime abnormal FBS is given, and so these are
Fetal
forceps you
compromise. Fetal
yes,
compromise.
yes,
Maternal prolonged progress of second stage of labor or combination.
or combination. Very good. So
Yes.
this you have to
About
learn this.
maternal.
But a new thing that has been added in this guideline lies in these two questions. Please understand this very well. So
Yes.
for Nali para, lack of progress for 3 hours. Now in these 3 hours, they
Yes.
are using both active and passive second stage of labor. In NICE guideline, what we used to do, they used to count only active second stage of labor. So this scenario has changed in this guideline. Now when they are calculating second stage of labor, they are calculating both active and passive. So while when you people will be giving exam, so it would be in January, almost 8-9 months previous this guideline has come. So answer will come from this guideline because this is recently updated. So you have to read this question well, because this part recommendation has changed. Okay,
Okay.
so
I have one questions here also. طيب Nali para women progress
hmm,
for 3 hours. Total active and passive. After
yes,
3 hours with regional anesthesia, I do
yes.
operative vaginal delivery after 3 hours if not deliver patient.
Yes, but they are including both active and passive second stage of labor. In NICE guideline, they have not included passive stage. So now the answer will change. Are you getting?
Because yes, because before in NICE guideline written passive second stage, we add 1 hour if we give the patient regional anesthesia, right or no? In
No,
NICE
previous
before.
in NICE guideline, whenever they were used to calculate suspected delay or confirmed delay, it was based on only active second stage of labor. They never included passive stage. Okay, but in this guideline, they have included both active and passive stages. Is it clear? So now
Yes.
you people have to read the question very well. So when you calculate the duration of second stage of labor, you have to include both passive and active stage and passive stage. So this is different, this guideline. Okay, so please read this very well, understand this very well. Otherwise, you will if you do it from the knowledge of previous guideline, then question will become wrong. So total progress of labor, it is for 3 hours if the patient has epidural, and it is for 2 hours if the patient has got no epidural. So in NICE guideline, In nullipera, they used to say more than 2 hours, you have to take action. So this is same, but calculation of second stage of labor now, according to this guideline, will include both active and passive second stage. So please understand this, then you answer your question. Otherwise, this question will go wrong. Is it clear now that how they are including both stage of the labor in calculation? Is it clear?
Yes, I have questions. Multigravida.
Yes,
1 hour.
multigravida again.
Yes, I
Yes.
have. Yes, multigravida. She is pushing about 1 hour and 30 minutes. يعني 1.5. Next step, what I will do?
So
Operative vagina or re-exam after?
no, if the patient has got regional analgesia, okay,
Yes,
then you can
she
go
has.
for half an hour more. But if the patient is without analgesia, 1 hour is already passed, then you have to take some action. Take some action. You can't
طيب
wait.
patient given for her regional anesthesia and 1 hour passive pass and 1.5 hours pushing. Should be take action operative vaginal delivery or re-exam
Yes.
after?
No. You have to take action because more than 2 hours passed.
Okay,
According to
thank you
this
very
guide,
much. Yes.
according to this guideline, because
Yes.
now only this change is there for the calculation of duration of second stage of labor. You have to use both active and passive. So this is changed from previous guideline.
Yes, thank you very much.
Okay. So again, this we have discussed. Low forceps can be applied for bleeding disorders. Okay, but vacuum is usually avoided because that otherwise hematoma will form. This part we have done, that below 32 weeks there could be formation of cephal hematoma, intracranial hemorrhage, subgaleal hemorrhage, and neonatal jaundice. Therefore we are so much worried. So if you are not aware of the fetal position, so what do you think, ultrasound is better than clinical examination for assessment of the fetal position?
Yes, ultrasound more reliable يعني fetal head position. Yes, better than
Better.
clinical. Yeah,
Yes, but they have
more
not
reliable.
specifying. Yeah, it is better, always better, because ultrasound, it will you can see the head of the position of head, so it is better. But there is no recommendation that either abdominal or perineal ultrasound. Okay, so that evidence is not there to
Mhm.
recommend routine use for ultrasound is not done. But if any confusion is there, consideration can be done because it will give you better clinic picture. Okay, so this is again safety criteria. For part 3 people, you have to learn every point of this table by heart, because it usually comes in the viva questions. Okay, but part 2 people also you have to remember. So this, though we have done it, so for abdominal and vaginal examination, this I have already explained you. So head has to be less than 1/5 palpable per abdomen, fully dilated cervix, station 0 or below 0, position you have to know, OA, OP, OT. Caput and molding should not be more than +2. Okay, I think this part they have newly added in this guideline. Previously it was not there. So please remember this. So if the caput and molding is more than 2, or
Yes,
in that particular situation, you have to send this
CBD.
patient cesarean section. You can't apply forceps. Okay, be careful. This point is important to remember. They have added new.
Yes.
Then preparation of mother, nothing new has been added. Consent has to be taken and documented, and patient has to have analgesia. Bladder has to be emptied. If the balloon is there, please deflate it. asepsis has to be maintained. Preparation of staff, again your trolley checks or equipments lighting bed has to be there. You have to have a backup plan. Like if the mid cavity forceps you are applying, you have to make it sure that the senior person should be doing it. Otherwise, or you have to make it sure if it fails, then theater should be there so that cesarean section can be done. Again, you have to think of complication. Shoulder dystocia, tear, and PPH can happen. Okay, so this everything is from the previous guideline, but this point has been added new. So this you have to remember. This will necessary for part 2 people mostly, because that will help, that will modify your answer. If you find caput is more than +2, put your answer as C-section. Okay, so if the forceps has to be applied in the room, so what type of consent is required?
Verbal consent in room,
Yes,
written consent in theater.
yes. So if any rotational forceps you are applying and you are taking this
Mm.
patient to theater, you have to take written consent. Or but in the labor room, verbal consent will go.
Verbal consent, yes.
Yes, okay. So do you know what is Montgomery rule? Any idea?
Patient understand maternal risk. Should be explained for patient maternal risk about what I do about intervention.
Yes, it is right, but I'll explain you the whole story behind. Actually, what happened? There was a patient. She Montgomery was a patient. She had diabetes, and she was given when she came for discussion of options. So doctor he just said explained that patient about the vaginal birth, and this baby she had when she delivered this patient she had a shoulder dystocia, and I think some injury was there to the baby or something happened. So this sue that hospital and doctor. What this Montgomery said, that doctor never explained me my option of cesarean section, otherwise I would have gone for direct for cesarean section. Okay, and because of this case, this hospital has to pay very high charges. After that case had happened, they put a new law. So this is a Montgomery law. In this law, what they said, that patient should know everything. Okay, so therefore they have put this in a law. Patient should understand material risk from any medical interventions and risk, or any of any reasonable alternative. So alternative patient has to you have to explain. For example, how it can be asked in the exam. It is important for part 3 people. If your patient you are going to apply forceps, so you have to give her option of cesarean section also. Maybe your patient will go for cesarean. She will say, no, I don't want to go for forceps, doctor, I want cesarean section. Okay, because all the complication of forceps, that tear and everything will not happen with cesarean, though cesarean will have different kind of complication. But as a part of you as a doctor, you have to give her both options. She will choose what she wants. So this is the Montgomery law, and you have to, both 2 and 3 people have to know it, because in part 2 people you will get direct question from Montgomery law, but for part 3 people, they will give it in the role player station. Okay. So if you have to take a consent and patient is in a pain, contractions, so you have to you can take consent when the contractions are not there. In between contraction, that consent can be taken. Okay. So now who should do? Who will do this vaginal operative delivery?
Doctor? Yeah.
Yes, who will do vaginal delivery? Who will do operative vaginal delivery? Okay,
Any doctor has
offsetting.
knowledge about vaginal
Yes.
birth.
Yeah. So actually, like it is not in UK, the things are not like we or in other part of the the world. Usually, in our kind of settings, we see our seniors doing it, and in their supervision we do it. Okay, but in UK things are different. In UK, before they are allowed for any kind of independent work, they usually has to be signed off. So their competencies has to be signed off, and how this competency is signed off? By OSET. Usually for every procedure they have to sign, they put three OSET form, sign three OSET form. When three OSET forms has been signed, then they will be assigned a competency. Once their competencies has been checked off, then only in the UK people can do unsupervised birth. Until these competencies are signed off, they cannot do it. Okay, in that particular situation they have to do it under direct supervision. So this is real important for you guys to know it off. Now this is OSAT. This I have already explained. Now they have start asking question about OSATs also. So you should know about this OSAT. So there are formative OSAT and summative OSAT. Two type of OSATs are there, and they have to sign three summative OSAT, pass three summative OSAT before they signed off their competency. So this you should know, need to know. Again, this is also important. So usually how they ask this line as a question, they will say there is one consultant and he is doing so many deliveries, rotational deliveries. In all rotational delivery, some complication is happening. So we are like department is real worried. So why so much complication is happening? So they will give you four choices, and what will be your answer? How they can they can keep eye on their performance, why complication rate is increasing, what they should do?
Audit.
Audit. So answer is audit. So now you can see once trained, it may be useful for the practitioner to audit their performance. So if you find in your exam any such kind of scenario is there, so answer that some complication is increasing, then in that situation you have to monitor and find out the reason for it. You have to put audit in the place. So this is really this important. Okay, so this part we have done. So what kind of thing can be done in the labor room? So low outlet forceps delivery or easy lift out assisted delivery can be done in the birth room or labor room. And if any rotational or if any like mid cavity forceps is there, usually chances of failure is very high. So trial has to be done in theater, and where the things for cesarean sections are ready. There is a table in at the end of the guideline. You need to do that table, so the things will be easy. Now this part is important for both 2 and 3 people. You have to remember this, because in teaching station for part 3 they will put one of thing from here. Then you have to explain about a rate of failure, why the assisted delivery high rates of failure are there. For part 2 people direct question can come. So what do you think, what are the conditions where high rates of failure will be there of assisted
Big
birth?
mother, big baby, occipito posterior, mid cavity. Very easy. Big mother,
Yes.
body mass index more than 30, but new, short maternal stature, yes. And
And head
fetal body weight estimated fetal more than 4 kg.
yes, you
Head
have to remember.
circumference,
Yes, more than
yes,
95th percentile.
95th. Yes. Occipito
So
posterior, mid cavity.
yes, so this part we already knew. Only new things has been added in the guideline: short maternal stature and head circumference more than 95th centile. Okay, so this part you have to remember. You have to do this by heart. Nothing can be done. Okay, so if one instrument you have to use, so what should be the instrument you should use if you are given a choice?
For what?
If the for assisted birth, if you have to use Ventouse or
Should be,
Forceps.
yes, most appropriate for my cases or for my clinical situation.
No, for like for clinical situation for the question. So if both are okay,
Give
so which should be given preference? Ideally Ventouse. Why? Because Ventouse is mother friendly. With a Ventouse, this perineal trauma is very less.
yes,
Okay, so if you get a question where you think both answer could be there and you have a choice, so more preference should be given to Ventouse because of less, because it is mother, Ventouse is mother friendly, less chances of perineal trauma or tears are there. Okay.
yes, yes.
Okay, so usually rotational, okay, who will do rotational delivery, that we know already. Expertise will be, it has to be done by the expertise. Without expertise, it cannot be done. Now this table, vacuum extraction comparison with the forceps. So only this you have to know that vacuum is less likely, that we already discussed, because vacuum
Yes.
is mother friendly. So it has got one important thing, that it is less likely associated with maternal, perineal and vaginal trauma. Okay,
Yes.
so if you have to remember one thing from this table, just remember this.
Mm.
Okay, this what are the numbers? This number I have
Very
put in the
good.
slide, so I'm not doing it again. Now you can be asked about this. What is odon device? What is odon device?
A new low, a new low cost instrument.
Yes. So maybe for part two people, maybe it is important. They ask, odon device is a simulation instrument that will help with the minimal training, so that can be of used for assisted birth. So just you need to know if anytime it come in the exam. Okay, now the vacuum delivery, what the guideline says. So when you have to discontinue vacuum delivery.
If no progress with me, if I will do vacuum, but no result, should be stopped.
Yes. So usually we apply traction. So with every traction, usually we put finger, and if we can see progressive descent. But if there is no descent, what
Stop.
we will do? We have to discontinue it.
Discontinue.
Okay. So this is new in the guideline. So previously, maximum number of pole, what we used to say is 3.
Triple.
Now what they have added? Now what they have
Stop
added
if
new?
no progress. Yes.
No. Previously there were 3 poles. Now they have, what
Yes.
they have added? What they have added? This
First
part
to
they
pull.
have, no. I'll just tell you. So previously, what we used to read, that within in 3 poles baby should deliver. But in this guideline, what they are saying, so majority of cases will be delivered in 3 pole. But if 3 poles are there, but head has come down, but head is sitting on the perineum. So in this situation, when descent is there but head is lying down on the perineum, additional 3 gentle pull can be applied to ease the head out of perineum. So this line they have added new. Okay, so in this, maybe you get question from this line. So what type of question can come? So like forceps vacuum has been applied, but head baby came down and baby's head is lying on the perineum. What should be the next step? So according to this guideline, your answer will be 3 more additional pulls gently can be applied to ease the head out of the perineum. So this is new in this guideline. Okay, so please remember it well.
So, ma'am, does that mean 3 plus 3 total 6? Does that mean?
Yes, it is 6, but you have to understand that 3 pulls till perineum. If the baby had come 3 or lying on the perineum, then only you can apply additional 3 gentle pulls. Total number of pull, like from above, you cannot pull 6. You can give more 3 pull. It is just to take out the head, because sometimes you see when we are delivering, so baby has come down and we can see head, but it is not coming down. If such kind of situation is there, then only 3 pulls can be done, but descent has to be done within 3 pulls only. Is it clear? Is it
Yes, ma'am.
clear?
Clear. It's clear. Yeah,
Yeah.
yes, ma'am.
Yes,
It's
yes.
clear.
Yeah.
Thank
So this part you have to understand well. Otherwise, you won't be able to do. We will make mistake in the questions. It is important for part 2 and part 3, because part 3 people, I'm either a role player station or Viva station is going to come, because this is a recently updated guideline. So now, if to vacuum, someone is applying vacuum. So with every pull, we just see whether the progressive descent is there. But with the first 2 poles, if it is suboptimal, in that particular situation, we need to rejudge the condition. Either fetal position is incorrectly diagnosed or some CPD is there. And in that particular situation, if after 2 pulls, you're not able to find out that baby is descending, please don't continue. That moment of time, either you have not assessed the patient well, or you can tell you can take help from the your senior person. So this part you have to understand. After 2 pull, no descent, please take advice from someone, or please reassess the position. This is again newly added in this guideline. Then after 2 pop off, you have to discontinue. Okay, so this is same. In previous guideline also it was after 2 pop off, you have to continue. You have to discontinue the vacuum birth. And after one pop off is there, like you applied a vacuum and it comes out. In that particular situation, you can reassess, you can take help from the senior support. But total 2 pop off, you have to discontinue this vacuum, because then it will like against the safety. Okay, so this part is important. Is it clear? Is it clear?
Yes, yes.
Okay. So
Yes,
what
ma'am.
do
It's
you
clear.
think?
It's clear. Thank you.
Yeah, fine. Okay. So what do you think? If you rapidly increase pressure and if you gradually increase pressure, will there be any difference in outcome? So there will be no difference. No
No
difference. If
differences.
yes, no difference. So like you need to know that then again sequential, like if the forcep fail, if the vacuum fails, and if you then next will be forcep, so it will be sequential use of forcep. So instrument, whenever the sequential use is there, in that particular situation you have to assess whether doing cesarean section at this full dilatation will be okay, or applying 2 instrument will be okay. So there is not a a single guideline
Balance.
cannot be. Yeah, you have to balance, you have to balance. But if the two instruments or sequential instruments are used, then baby's morbidity will be more. So you have to make it sure that neonatologist should know this, and also chances of sphincter injury will be more if you are using two instruments. So this may be asked in the exam. Okay, chances of sphincter injury will increase with two instruments. That you can see there will be so much of trauma to maternal perineum, so tear can happen. Okay, so that's all they have given about Ventouse. So you have to understand this part of it, that with the three pulls it should come down to perineum, but if the head is sitting on the perineum, gently 3 additional pull can be applied. So this is a new thing that is added onto the guideline. Second part, after 2 pop off, you have to discontinue it. Okay, now about the forcep also what they are saying. So if the this we have done also. So if the forcep blades are not applied easily, that we were doing safety checks before putting traction. So if that safety checks are not there, that means forceps are not applied easily. In that situation, you have to discontinue. Okay, wrongly applied forceps, you cannot put pressure. So this is a safety point. Therefore, there is so much of emphasis on right application of the forceps. Then if whenever you are applying traction and baby is not coming down, there had been no descent, you have to discontinue. Okay, so this is about the conventional forceps. In case of rotational forceps, usually they give gentle pressure or fingertip pressure for rotation that I discussed. If rotation is not done with just gentle or fingertip pressure, you have to discontinue. That means something wrong is there, or in that particular situation you have to abandon it, because extra pressure you cannot apply. You are going to do some harm to baby or mother. Again, in the 3 pulls, if the so for the forcep it is 3 pull. If a forcep is rightly applied in the 3 pulls, if the baby is not coming down, please discontinue this forcep. So these are the few safety points. So when you have to discontinue that part also, if the teaching station comes, you have to speak to your role player, and also you have to know this for the part 2 also. This part is same, like if the failed instrument is there, then baby's morbidity will be more. You have to bring neonatologist in the picture, and like if like if forceps are failed, when usually we apply forceps, so it usually causes impaction of head in the pelvis. And if you are taking patient for cesarean section after failed forceps, okay, in that particular situation during cesarean section, they have to disimpact the fetal head, because so doing cesarean section after failed forceps will be difficult because of fetal head impaction. Okay,
Okay.
this is important to remember. Yeah. Okay, medial lateral episiotomy that we did. Now this is important. So at what angle it should be 60-degree, and head has to distend perineum. This is also important. Okay, so 60-degree. Now what about prophylactic antibiotics?
Single dose amoxicillin and clavonic acid should be recommended.
Yes. So this is newly added in the guideline. You may get question from here. Single dose of amoxi and clavonic acid. Apart from this,
Augmentin.
what? Yes. What they say about VTE?
Venous, if mid cavity or rotational, score 1.
Okay, that they're not, I'm not asking about that, but in any assisted delivery, you have to.
I mean reassess after delivery,
Yes.
after assist, yes.
Yes. So this point, it is important because it will for part 2 and part 3 people both.
Yes.
So, yeah, PD risk assessment is important. So what kind of analgesia can be given?
Paracetamol or non-steroidal anti-inflammatory drugs.
Yes,
Yes,
these are
routine.
recommended. And so after assisted birth,
Bladder emptying
yes. So when the bladder is emptied, for whether the patient has voided first time,
first avoided should be monitored and documented.
yes, timing, volume should be monitored
Yes.
and documented. And
Yes.
if you think that any post-voidal residual volume is there, then if you think urinary retention is there, you have to do measure PVR. It can be done either putting catheter inside, or it can be done with use of USG. Okay, so USG, bladder scanning, or catheterization. With these two methods, residual volume can be measured. And it is important to avoid any kind
Yes.
of postpartum urinary retention. Why? What it will do?
Associated with
Long.
long-term bladder dysfunction.
Yes. So we have to be very careful about bladder emptying. If the patient
Yes.
has not passed urine, we have to like put some catheter according to the hospital protocol, because if postpartum retention continues, long-term bladder dysfunction may happen. So we are very worried.
Yes.
Again,
Better ultrasound also. Yes. Infection.
yes, yeah. And like if the epidural has been given, so how long indwelling catheter should be kept after delivery?
12 hour.
It is 6 to 12. Okay. So in
Yes.
previous guideline, it was 6 hours, but in this guideline, it is 6 to 12 hours. Along with it, fluid balance chart has to be maintained.
Yes.
Okay. Okay, so this again, whenever this kind of delivery is there, usually patient, psychological morbidity may be there. So the best practice, this patient should be debriefed by the doctor, okay, who had done the procedure. So this line also you will find any question, many time question comes that who will debrief. Usually the best approach, the doctor who has done the procedure. It should not be any other person. And usually mother and birthing partner both should be should have a complete discussion. And usually if you have to offer a psychological intervention, so please don't offer one session. How one session will not be enough. So this patient will require many times to see a doctor. So please, according to this guideline also, don't offer single session. Okay, that's all about this guideline. Okay, and also if this time assisted vaginal birth is there, so patient should be explained that in future birth chances of spontaneous vaginal birth are very high. In previous guideline it was 80%. I think this is, they have also given this 80%. Yeah, again what you have to remember is this table. This table is real important, that will help you answering a number of questions. So this is we called this as a documentation. So this is assisted vaginal birth record form. Okay, so usually after every assisted birth, they have to fill it. They have to fill it. So just go one through about it. So that will be good. Now
This
this
is
is,
important.
yeah, this is important. So that will help you in answering many of the question. When you can do a labor room delivery, only if you are applying low or outlet forceps. Okay.
Yes.
Yes. And this is real important when you will take patient to theater, when it is mid cavity or rotational forceps.
Yes.
Okay. Now coming to selection of instrument. So this you have already explained very well. So
Yes.
yeah, with the Ventouse less than 32 weeks, we should avoid
Okay.
and caution 32 to 36 weeks. This you have to remember. Yes, again, correct application of instrument. So unless correct application of instrument is there, you cannot apply any traction. If it is incorrect, please please either you reassess yourself or you take second opinion. Either you discontinue or you take second opinion. But and whatever you apply, forceps or Ventouse, it has to be correct application. Okay, so this part like we have done. So before the traction, we need to make it sure that if the descent is not there, like we have checked that instrument correction is fine, there is no CPD, and then also if there is no descent, what you will do, you have to discontinue that procedure. That means something is wrong. And vacuum, when you will discontinue if more than 2 pop off of that vacuum pull is there. Okay, this part we have done. Now they have put it again. If usually with the vacuum, delivery should happen within 3 pulls. Okay, but if the head is lying over the perineum, then gently additional 3 pulls can be applied. Fine. This is just the sum up. Now, if the delivery is failed, if sequential instruments are used, so there will be more trauma to maternal perineum, and what can happen? What can happen is the sphincter injury. So we have to be very careful. Again, once the delivery is there, what performer, what was I have just shown before, completion of operative vaginal birth delivery has to be done. Debriefing is important to mother, partner, and family. Okay, so these are the important things about this guideline. Now, if anyone of you has to ask me any question, you can ask. Otherwise, I will be asking you questions. Any question?
Thank you so much.
Okay, welcome. So, before answering part 2 questions, I just make some summary so that will, maybe of help. So, how to decide in your question whether assisted birth should be an answer or cesarean section? What answer you should put? It is assisted birth or cesarean section. Then these are the few, tips could be there. So, check for dilatation. Anytime, if the dilatation, if you find dilatation is less than 10 centimeter, okay, in that particular situation, you cannot do like instrumental birth. If dilatation is less than 10 centimeter, you should send this patient for cesarean section. So on the basis of dilatation, you can make this decision. Now, in your question, if they have given station, just see where is the station. If it is below spine, go for assisted birth as an answer. If it is above spine, you have to put cesarean section as an answer. Then in your station question, if they have given capital molding, if it is +2, capital molding +2 or less than +2, then possibility of assisted birth. But if they have given capital molding more than +2, this patient would require cesarean section. Then this is the assessment of assisted birth and cesarean section based on the findings of dilatation, station, capital molding. But if they have given PA, if you find any time in your question head is more than 1/5 palpable, put cesarean section as an answer. Okay, so these are the few clues, just putting them in your question, you're answering will be easy. This is one thing. Second, which delivery has to be in the labor ward? Labor ward, it will be low pelvic deliveries. It could be only done in the labor ward. And if any rotation required, if mid-cavity forceps is required, in that particular situation, head is 1/5 palpable. Okay, so more chances of failure, you have to continue it in theater. So this is the sum up of all the points that will help you answering the questions. Then how to answer again. Now this will help you in answering whether it should be whether it should be cesarean section or assisted birth. Then these are the clue. If you are stuck, whether what type of instrument and what we should answer. So this will be like, just if the forceps is there, then just see this +2. If it is less than +2 or 0 to +2, it has to be mid cavity forceps. If it is +2, your answer will be low, and more than +2, your answer will be outlet. So just remember this formula, though it is nothing, sum of your guideline only, that will help you in answering your question, what type of forceps you have to apply. Then in your question, if it is excessive, more likely forceps is an answer as compared to Ventouse. If you have decided for assisted birth, if caput is there in that particular situation, most probably you will put forceps as an answer. Why? Because with the vacuum, this pop off is too much. Okay, prematurity, if it is less if it is less than 36 weeks and you think of apply instrument, because with 32 to 36 weeks, it is with very caution in vacuum. In this particular situation, if it is towards preterm and you want to apply, you have to apply forceps. Face presentation after coming head of breech, only forceps is an answer. And if any condition is there where mother cannot push, cardiac condition, instead of putting answer as in vacuum, your answer will be in forceps. If any coagulopathy, what we read just now, answer will be more likely forceps. So this is a sum up that will help in making your decision, whether you put forceps or whether you put Ventouse as in your answer. So this will help in deciding whether cesarean section or assisted birth. This will help you in making your decision, forceps or Ventouse. So anyone has to ask any question can ask, otherwise I'll be putting questions. No question? That good. So now you have to answer.
Hello.
Yes.
Ma'am, I would like to ask that in last guideline, they had kept this criteria that primary with epidural until 4 hours we can wait after full dilatation. And now this guideline is saying with epidural 3 hours. So in the questions, if the exam comes, so what we should follow? The old guideline or this new guideline?
New, everything updated. New
Okay.
guideline.
Okay,
Just
ma'am.
revise this
Thank
table the night before your exam, otherwise
Okay.
you will make mistake. So this table is real important.
Okay. Thank you, ma'am.
Okay, so now there will be questions. These are questions from strategy. Okay, someone has to answer.
Then proceed directly for cesarean.
Yes. Now what is the keyword? 2/5 head. 2/5 head is a keyword. If the head is
Yes.
more than one, yes, this is the
Yes.
this is the keyword. What is the
Yes.
buzzword that will help in answering is 2/5 the head palpable. Answer has to be
More.
cesarean section.
Yes. Trial initiator.
Yes. Why?
Right.
Because
+1
now
station, mid
plus
cavity, and
yes,
occipito-posterior rotational should be rotational.
yes.
Yes.
So there are two
Very
keywords.
important.
Yeah, +1
Yes.
station and 0 to +2
Mid
is our mid cavity and ROP. So mid cavity and rotation, take the patient to theater. So answer is so easy.
Yes.
Forceps delivery.
Yes. Now here it is +1.
+1. +1.
Level band.
Yes,
Level
+1
one
that
forceps.
and it is Neville Barney. +1 is a mid
Yes.
cavity. Again mid cavity and kappa 2+. So kappa 2+ go for forceps. Mid cavity will go for rotation. Rotation again it can be for rotation thing. Usually it is in the theater, but that option is not there. So with a pudendal block in it can be done. Okay. So answer will be Neville Barney.
Wait 1 hour.
Patient has ITP. Second stage of labor, second stage of labor 2 hours, actively pushing 1 hour. So already 3 hours are there. So you have to do something. After 3 hours, you cannot wait.
Ma'am, isn't this 1 hour of active pushing included in this 2 hours of second stage?
Okay, so okay, then also she's not 3 hours if patient is in epidural, 2 hours without epidural. So here there is no epidural. So 2 hours you have to do some action. You can't wait.
Vertex +2.
Then kiwi cup delivery, ma'am.
Occipito anterior. Occipito anterior.
Kiwi cup delivery. Because
We can
there is
give
no
in
caput. Oh, but it is ITP. ITP, we cannot apply cup. Sorry.
So
Nabil,
Low
room
forceps.
B is answer.
Checking for contraction, starting symptoms of infusion.
B is
Yes,
answer.
low force.
no, but contraction there, what about, they have not mentioned anything about contraction. So you have to assume that, okay, actively pushing, that means contractions are fine.
Okay.
Yeah, low forceps, doctor.
Yes, answer will be forceps only.
Yes.
They have got a very big buzzword here.
E is answer.
Syntocinon infusion.
Yes, contraction 2 in 10. You have to have a contraction 4 to 5 in 10. Answer will be Synto.
Cento, yes.
Okay, because CTG is fine. Baby is doing well.
Normal, yes.
So every question, try to find out buzzword. Do it mathematically.
Occipito-posterior position.
Yes.
Prematurity here.
No prematurity because we cannot apply vacuum in prematurity.
Yes. Answer is OP.
Uh-huh.
A.
A is answer.
Yes. I just told you. So it has to be done by a doctor who did
Yes.
the.
Briefing by doctor, yes.
Yes.
Prematurity.
Yes, it is clear.
Yes.
So there is only one buzzword that can give you answer, you know.
CS.
Yes.
2/5.
Yes.
But
Yes.
well, just see one word and you put your answer. 2/5 is
Yes.
very.
Non-rotational
So
forceps.
non-rotational forceps.
Yes. A, B, C.
Why forceps?
Okay, caput
To check
should be
them.
chosen when, sorry, Ventouse should be chosen when we have the option for both. So in this
Yes.
case,
Answer will be Ventouse. See, no, you can get clue from the question. They are saying no caput, no molding.
Kaput no
That
molding. Yes. Ventouse.
they want you to apply vacuum. But if they say plus to caput, your answer will change to forceps.
Mhm.
Okay. So read very carefully or find out buzzword. You will get answer very clear. So there are two buzzwords here.
Trial instrument delivery
Trial
initiator.
delivering
Occipital
initiator.
transfer.
Yeah, so
Plus
there
one.
are two buzzwords. Plus one is mid cavity forceps
And
and
left.
occipital is rotational. So with two buzzword, your answer become theater instrument.
can you please explain this again?
Okay, now I'm not reading everything, but I'm just reading this part of it. Okay? So head is plus one. So if the head is in between 0 to plus 2, that will count for
Mid
mid
cavity.
cavity. Okay. This is one buzzword. Second, baby is in OT position. That will call for rotation. So mid cavity forceps and rotation. So you have to do it in a theater. So see what will be the answer. It will be trial for instrumental delivery in theater. Is it clear?
Yes, ma'am, clear. Got it. Thank you.
Yes,
Just look
ma'am.
for buzzword. Do it like a mathematics. Okay, this question actually according to this
Same
guideline.
oxytocin
rotation.
compares women with epidural anesthesia.
No, this is
Epidural
okay.
anesthesia.
Okay, answer I'm telling you, in some of the studies, manual rotation.
Manual rotation, yes.
Yes, but in this new guideline, they have not recommended this. So, like this is the you should not, this type of question will not come because they have not put it. New guideline, they don't want any kind of manual rotation. Okay, so this answer is manual rotation, but in this guideline, there is insufficient evidence. Okay, insufficient evidence is there. Only some of the studies says that manual rotation helps. So this type of question will not come, but it is again from the old guideline.
A.
A.
Neonatal intracranial hemorrhage.
Yes. With the vacuum, so much of pressure is there, all subgaleal hemorrhage, intracranial hemorrhage, retinal hemorrhage will happen.
Ma'am, actually, is there intracranial hemorrhage? It's written only subgaleal hemorrhage, right? Guideline.
Yes, subgaleal hemorrhage are more common, though intracranial hemorrhage also happens.
Okay, ma'am.
Mento anterior position.
Mental
Yes.
anterior.
Mento anterior.
Yes, because in face,
Mento anterior.
so these are the options. Okay, this is the question. Big question you read.
Ma'am, please show the
Options,
options.
F.
F category.
Category 1.
Why at 9 centimeter dilatation you want to do category cesarean section? So at 9 centimeter you can send this patient to theater and you can reassess. Maybe by the time you take this patient to theater, she's already with 10 centimeter dilated. So you would reassess. You will shift to theater and reassess. So in the theater, if she is still 9 centimeter, this would require cesarean section. But if she's fully dilated, consideration for even instrumental delivery can be done. So this finding.
Ma'am, if she's primary.
So what?
Hello?
Yeah.
Hello, ma'am. If
Madam?
she's primary.
Hello.
Yeah. If she is primary also, then also instrumental birth can be done.
Okay, ma'am.
So before you do cesarean section, you have to reassess, and reassess has to be done in theater because this patient, she has got pathological CTG, the fetal heart rate dropped down. Okay, so if this answer they have not put in the options, transfer to theater for reassess, then your answer will be cesarean section.
Okay, ma'am. Thank you, ma'am.
Hello.
Yes.
In the last question, the last line was showing that the fetal heart rate didn't recover. So it
Yes.
has to be shifted for cesarean, na?
Yes, you are shifting this patient, but you will reassess in theater. You have to take out this baby as early as possible. Okay, cesarean decision and doing cesarean will take lot of time than putting that instruments. So she is 9 centimeter. By that time you will shift her to theater. You will reassess her. If she is 10 centimeter, apply some forceps, that you will be able to take out baby more early than cesarean section. This we do in our hospitals daily. So if this kind of patient is there, we will shift her immediately, and before any cesarean section we will again do her PV in labor ward, in a theater. If she is fully dilated, we will think of forceps first. Okay, so this is common thing.
CS.
CS. Why CS?
Breech
Options, ma'am.
extraction.
Breach with
Ma'am, options, please.
abnormal
Is it
heart.
either options same? We can shift her to theater and reassess.
Ma'am, options, please.
Yeah. See, breech is descending through birth canal satisfactorily and stationed below ischial spine. Why cesarean? Why cesarean?
Forceps.
You can wait also. You can reassess also. Assisted vaginal breech can be offered to this woman. Assisted breech birth.
L.
Yes, answer is L. There is no indication for why you will want to send this patient for section. Breech is descending very well. This is one clue. Second, it is already below spine. Fine. So you have to arrange for assisted breech delivery. Answer is assisted or instrumental delivery in labor ward.
One question, please.
FB has included something.
Two-fifths per abdomen.
What you're saying?
Two-fifths. Again, questions.
Question. Okay.
Cephalic with two-fifths palpable.
So, yes,
Ma'am, reassess in 2 hours.
no variability,
Yes, no variability.
no
40 minutes.
acceleration.
Yeah, rupture of membrane.
Abruption is there, bleeding, abruption.
Yes.
At 5
Okay.
centimeters, then go for cesarean section.
Yes.
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 Answer is F or G.
F.
Yes, it is category 1 cesarean section. If you don't do at earliest possible, baby will go. Baby will die. So there is threat to baby. Go for category 1 cesarean section.
Yeah, oxytocin infusion.
Before that, what you will do?
ARM.
Do PV and a PV at least. So what will be the answer? So what is the answer?
E.
Search. E.
B.
Yes, very good.
B. B.
Yes, before Synto, we have to do vaginal examination because they have not given any vaginal examination. So
Yes,
smart. No vaginal examination they have given. Okay. So appears to be so easy thing, but we can easily miss it.
Options ARM.
I think it will be
I,
cesarean
I,
only, ma'am. This
at 23
deceleration
weeks,
with
I
vaginal
believe
bleeding with breech presentation. It has to be a cesarean.
E, I
it's at
think.
23 weeks. At
Gestational
23
age.
weeks.
Okay, I
23.
It'll be I think.
Cesarean section by abruption.
But wait, at
Only
23 weeks, what will it serve?
one cesarean section.
Mm-hmm. Mm-hmm.
Should
I.
we be last option?
Ma'am, why not I? Membranes are
And then
intact.
induce ARM and commence oxytocin infusion. They have given answer as oxytocin infusion. Yeah, I will go for even I.
And because membranes are intact, so
Membranes
we
are
can do
intact.
ARM also.
Yes.
Yes.
Unless they want us to assume that membranes has no, membranes are intact. So yeah,
Intact, yes, ma'am.
I will go for this ARM.
Doctor,
Yes,
but
Breach late ARM.
there is abruption.
Yeah, in
ARM will
abruption,
release that also. ARM is
yeah,
indicated in abruption.
yes, in abruption also we need to do ARM to see how much bleeding is there. So ideally answer should be I. But this is RCOG question and answer. Okay, so I have whatever their answer is, I have put same. Bad questions. This is the last bad question. But in the exam, this long question usually comes. So, you have to have an idea.
FPS.
Yes, FBS is the answer.
FPS. Yes, ma'am.
Okay, now easy questions.
Trial of instrument in theatre.
E.
E.
Yes.
Yes, ma'am.
Now these are easy questions. Same I have put again or what? This is the same question. No, different answer is different.
D.
A. D.
Allow her to
Elma.
push for 1 hour.
Yes, allow her to, she is primary gravida, pushed for 1 hour, so you can give 1 hour more. You can give
Ma'am,
1 hour
she
more.
has been fully dilated for 3 hours in total, na? How can we give her 1 hour more?
She now fully dilated. Epidural is
Epidural
there.
D.
Was given 2 hours for the head to descend in the pelvis, then 1 hour more to push down. So, ma'am, it makes total of 3 hours.
Total of 3 hours.
Yes, ma'am.
And 4 hours is mentioned in the answer. 4 hours
No,
and
no, no.
second
Now
stages.
in new guideline, it's only 3 hours, including epidural. With epidural,
Yes.
it is 3 hours.
Yeah, with
So,
epidural
ma'am,
it
should
is
be
3 hours.
again in
So
even
according
In
to
a
new
new 3 hour, yes.
according to the new guideline, it should be E again, ma'am.
according to new guideline, it should be instrumental.
Yes,
In
Yes.
ma'am.
posterior position. So
Instrumentally go.
yeah. So it will be like it will
E
be
answer.
E. Yes, according to new guideline, answer changes to E.
In exam, we will answer E.
Yes, exam all answer will come from new guideline. This is easy question.
D. D.
Plus 2.
Delivery.
Plus 2 D.
It's E.
Uh,
In prime is +2
D.
position.
D.
I
It
think
is
it should be
plus
in
2, so
theater.
low forceps can be applied in labor wards. It's D.
yes,
Yes, D.
it is D. There is no indication for taking her to theater. Why you want to
Plus 2.
send to theater? +2.
Occipital anterior.
Yep.
Labor room.
Yes, labor room.
In prime is also, ma'am.
Yeah. Primary multi make no difference.
Okay, ma'am. Okay.
D.
A. A. Allow her to push for another 1 hour.
Yes, allow
A.
her to push.
Yes.
She has
Yes.
A
only fully dilated pushing for 1 hour.
for 1
1
hour.
hour.
No
Yes, allow.
epidural. They are using Entonox. So active. There has to be 2 hours of second stage of labor.
Full
She has
dilatation. Yes,
pushed
ma'am.
only 1 hour, so give 1 hour more. It is total mathematics. Give 1 hour.
Multiparas.
Okay, she is multi-para. So in multi-para,
Multiparas without
she has
2
epidural
pushed
1
hour.
hour
for.
will be.
Okay, if she is multi-para,
But ma'am,
after
in new
1
guideline, it was 2 hours for multipara,
Yes.
no?
No,
Total
no.
2
2
hours
Hours
It's
hours.
was
two
with
hours with
epidural.
epidural.
2 hours with
2 hours with
epidural.
epidural.
So this
1
patient
hour
will require instrumental delivery. So
delivery. Yes, ma'am.
so answer will be instrumental delivery in labor ward. Okay, fetal head is 1 plus.
1
So it is
centimeter.
mid cavity. It is mid cavity, and 1 hour
It
she has pushed. So you have to take some action. So answer will be E.
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 Mm.
So new guideline answer will be E. Okay, so their answer is A, but new
All
guideline
that.
answer E. New guideline answer E.
Oxytocin.
Zendo. Stop.
Because confirmed delay.
ARM has been done.
Yes.
They have said nothing about contractions. You don't know about anything about contractions.
The first time 5 cm. After 4 hour,
So
then done
this
IRM. Then after 2 hour 5 cm. Delay, yes.
it is delay. It is delay. So answer
Syntocinon and S.
should be what? Answer should syntocinon.
Syntocinon and re-exam after 4 hour.
Yes.
Yes.
Yes, but their
How?
answer is no. Their answer is epidural and syntocinon. Okay. Okay, whenever you put synto, epidural, a patient should have a pain relief.
Mhm.
So answer will be epidural and synto. Okay, epidural
Ma'am,
always
isn't it when patient asks for pain relief, patient asks for
no,
epidural, then we put it?
no. With syntocinon, always they give pain relief. Syntocinon, they will not never put without pain relief, and usually that pain relief is epidural. Okay,
H is
with
correct. Is not right. H.
syntocinon, two things you have to always bring in the mind, that epidural pain relief has to be there and CTG monitoring should continue. So their answer is epidural and oxytocin. This you will answer right.
Reassess in 4 hours.
Yes, re-examine. So oxytocin has been started, so you need to examine after 4 hours. Okay, answer. Why I have put answer? Okay, the answer is already I have put. So in this, she is spontaneous labor. Syntocinon is already there, but there is no progress. And if you look for dilatation, dilatation is only 6 centimeter, and she is in the delay in first stage of labor. Okay, so you have to consider deliver at 6 centimeter only. Cesarean section is the answer. Okay. Now I think I have forgotten the question slide. This is again answer slide has come. You can read it. If you find anything to be asked, you can ask me. So she is 34 weeks pregnant, full dilatation, OA position +2. So if it is 0 + 2, that means it is low forceps and low application, and she is 34 weeks, so Ventouse cannot be applied. So answer
Yes.
will come from low forceps. Low
Yes.
forceps will barne. Fine. So this is total mathematics again. Okay, I don't know. I'm not put question slide. So now patient has a thrombocytopenia. She is fully dilated and she has occipital posterior position. She's +1. So +1 means she is in mid cavity. Mid cavity usually answer forceps can be applied. Okay, but in cases of thrombocytopenia, usually forceps are applied. Mid cavity or rotational forceps are not applied. Therefore, answer will become cesarean section.
Yes.
Outlet can be applied, ma'am?
Outlet, yeah, that this can be applied. But coming to this finding, you have to apply
Yes,
mid
ma'am.
cavity forceps. Mid cavity
Yes,
forceps you
ma'am.
cannot apply in thrombocytopenia. So answer will become
Yes,
cesarean.
ma'am.
This is a good question, you know.
Yes.
Options, ma'am. FPS.
Yes.
FPS.
So babies had at
Vacuum.
Vacuum.
Vacuum delivery.
vacuum, but they have okay. So is vacuum there? So vacuum is there, but it is rotational. So it will not fit in your answer. So what will be the answer?
Like forceps.
Yes, it is
Outlet
forces.
forceps.
Yes. Regular forceps.
Yes. These forceps.
Mid cavity forceps.
Mid cavity rotational. Keyland.
Yes. Yes.
Mid cavity rotation.
So
Q.
they have yes, they
M.
have not answer is Q because they have not given mid
Q.
cavity forces.
Yes,
So
Q.
answer is rotational ventouse. Fully dilated OT or occipitotransverse position pulls for more than 1.5 hours. Rotational ventouse. Same kind of question.
Two. Mid cavity rotational.
Not cavity also.
P.
What you're saying? P. Yes, P is the answer. Rotational ventouse.
Rotational ventouse delivery.
Re-exam after 1 hour.
Syntocinon. Syntocinon.
Cento.
Why Sinto? They have not said anything about
Re-exam.
wet. She is fully dilated. Okay.
She has no urge to push.
In that situation, it is a direct answer question from the
Past
guideline.
experience.
If she has no urge to push, she can wait for 1 hour more.
Just
This is
re-exam
direct
after.
copy pasted from guideline.
Yes.
So the buzzword is
This
already there.
Into.
Yes.
thing.
Epidural and syntho.
Operative.
Into. Ma'am, question once more. Ventouse. You can apply
Three more
Ventouse.
pull can be given. Gentle pull.
So here, like head is sitting on the
Additional pulls.
so
We can give two more pulls.
yeah,
Wrigley force.
their answer is three forceps, but according to new guideline, 3 more pull can be applied.
Yes, ma'am.
Okay, so this is the now if this question comes according to new guideline, your answer will come 3 more additional pull because the head is sitting on the perineum. So very good buzzword.
Cesarean section.
Yes.
Cesarean.
2/5 head palpable, it has to be cesarean section.
Cesarean section. FBS is done.
Mid cavity forceps +1.
+1 mid cavity forceps. So mid cavity forceps only in theater. This is according to the new guideline. Okay, this is from the new guideline. So answer will be trial of forceps in theater. So answer is the same. Okay. So any one of you have got any questions? Can ask me.